What?
You ever noticed a child who always seems to have their mouth slightly open, looks tired even after a full night's sleep, and has dark circles under their eyes? This collection of features is sometimes called an adenoid face. It's not just a look, it's a signpost pointing to a hidden health issue. The term describes a specific pattern of facial development that can occur when a child persistently breathes through their mouth instead of their nose. This might seem like a small habit, but over time, it can have a big impact on how their face, jaws, and teeth grow. It often includes a longer, narrower face, a small or recessed chin, a short upper lip that struggles to close, and teeth that may become crowded or crooked. Parents should be concerned about the adenoid face because it is a visible signal that something is obstructing their child's natural ability to breathe. Proper nasal breathing is vital for more than just getting oxygen into the body. It warms, filters, and humidifies the air we breathe, protecting the lungs from irritants and infections. When a child cannot breathe easily through their nose, they are forced to adopt mouth breathing as a survival mechanism. This change disrupts the delicate balance of muscular forces in the face, which in turn guides how the bones of the jaw and midface develop during the crucial years of childhood growth. Ignoring these signs can lead to permanent changes in facial structure and a host of other health problems. Understanding this connection early on is incredibly important. The way a child breathes directly influences their well-being, from the quality of their sleep to their ability to concentrate in school. The features of an adenoid face are the external clues to an internal problem, often an airway blockage that needs attention. It's not a cosmetic issue, but a functional one that affects a child's overall health trajectory. By recognizing these signs, parents can take the first step toward addressing the root cause, ensuring their child not only breathes better, but also grows and develops to their full, healthy potential, with a confident smile to match. The concern goes far beyond just appearance. A child with these facial characteristics may be struggling with underlying issues that affect their energy levels, behavior, and even their long-term posture. They might be labeled as inattentive or hyperactive at school, when the real culprit is poor quality sleep caused by a compromised airway. This is why it's so crucial for parents to see the adenoid face not as a simple quirk, but as a call to action. It's an opportunity to intervene and set your child on a path to better health, guided by a deeper understanding of how something as simple as breathing can shape their entire future. So, what causes a child to switch from healthy nasal breathing to habitual mouth breathing? The most common reason is a blockage in their upper airway. Think of the nose as the main highway for air. If it's closed for traffic, the body will find a detour through the mouth. The primary culprits behind this blockage are often enlarged adenoids and tonsils. Adenoids are small pads of tissue located high up in the throat, just behind the nose, while tonsils are the two lumps you can see at the back of the mouth. In young children, these tissues are part of the immune system and can become swollen due to frequent infections or allergies. When they become chronically enlarged, they can physically obstruct the nasal passages, making it difficult or impossible to breathe through the nose. While enlarged adenoids and tonsils are the most frequent cause, they are not the only one. Chronic allergies, such as hay fever, can also lead to persistent nasal congestion, forcing a child to breathe through their mouth. Similarly, conditions like a deviated septum, where the wall between the nostrils is off-center, or nasal polyps can create physical barriers to airflow. It's a simple case of mechanics. If the air can't get through the nose, the mouth must take over the job. This switch isn't a conscious choice, but a subconscious adaptation the body makes to ensure it gets the oxygen it needs to survive. The problem is that this adaptation, while necessary in the short term, becomes a harmful habit over the long term. The mouth is not designed to be the primary breathing organ. It doesn't have the sophisticated filtering and humidifying mechanisms of the nose. More importantly, keeping the mouth open to breathe rewires the muscle memory of the face. The tongue, which should rest against the roof of the mouth, drops down and forward to open the airway. The lips, which should be sealed at rest, remain parted. This constant open mouth posture becomes the new normal, even if the original blockage is eventually resolved. Therefore, identifying the specific reason for your child's mouth breathing is the critical first step. An ear, nose, and throat specialist can examine your child to determine if enlarged adenoids, tonsils, or other structural issues are the source of the problem. A pediatric allergist can help diagnose and manage allergies that may be causing chronic stuffiness. Understanding the root cause is essential because the solution must address the reason for the blockage. Simply telling a child to close your mouth won't work if they physically cannot breathe through their nose. The journey to better breathing begins with clearing the path. The shape of our face and the alignment of our teeth are not predetermined at birth. They are actively sculpted during childhood by the forces around them. One of the most powerful guiding forces is the proper function of our facial muscles. A simple way to understand this is through what experts call the functional matrix theory. This theory states that bones don't just grow on their own. They grow in response to the functions of the soft tissues and muscles surrounding them. In the face, the tongue, lips, and cheeks create a balanced matrix of forces that guide the jaws to grow forward and wide, creating a broad, healthy smile with plenty of room for all the teeth. When a child breathes through their mouth, this delicate balance is completely disrupted. The tongue, which should act as a natural palate expander by resting against the roof of the mouth, drops to the floor of the mouth to let air pass. Without the tongue's gentle, constant pressure, the upper jaw, the maxilla, doesn't receive the signal to grow wide. Instead, it tends to develop into a narrow, high-arched shape. This creates a domino effect. A narrow upper jaw means there isn't enough space for the permanent teeth to erupt properly, leading to severe crowding, crooked teeth, and a V-shaped dental arch instead of a healthy U-shape. Furthermore, the constant open mouth posture affects the entire facial structure. With the mouth hanging open, the lower jaw, the mandible, tends to grow downwards and backwards instead of forwards. This contributes to a longer, flatter facial profile and a recessed chin, classic features of the adenoid face. The muscles of the cheeks, no longer balanced by the tongue, can exert inward pressure on the jaws, further narrowing the smile. Even the lips are affected. The upper lip can become short and weak, and the lower lip may look overly pronounced as it sits beneath the upper teeth, a condition known as a lip trap. These changes are not just aesthetic. A narrow upper jaw is also the floor of the nasal cavity. When the palate is high and constricted, the nasal passages above it are also narrowed, making nasal breathing even more difficult. This creates a vicious cycle. The airway obstruction leads to mouth breathing, which alters facial growth in a way that further restricts the airway. This is why early intervention is so critical. By correcting the breathing pattern and restoring proper muscle function during the formative years of growth, we can guide the face and jaws back onto a healthy developmental path, preventing these issues from becoming permanent skeletal problems. The consequences of chronic mouth breathing extend far beyond a child's facial appearance and dental health. This seemingly simple habit can trigger a cascade of systemic health issues that affect a child's growth, learning, and overall quality of life. One of the most significant impacts is on sleep. Mouth breathing is closely linked to sleep-disordered breathing, including snoring, and even obstructive sleep apnea, a condition where breathing repeatedly stops and starts during sleep. This fragmented, poor-quality sleep means the body and brain are not getting the deep, restorative rest they need to function properly. For a growing child, this sleep deprivation can have profound effects. Growth hormone, which is crucial for physical development, is primarily released during deep sleep. When sleep is constantly interrupted, hormone production can be disrupted, leading to slower growth and what is sometimes termed failure to thrive. A child might not gain weight or height at a normal rate. They will also likely feel perpetually tired, which can manifest not as sleepiness, but as irritability, hyperactivity, and difficulty concentrating. Many children with undiagnosed sleep-disordered breathing are misdiagnosed with attention deficit/hyperactivity disorder because the symptoms can look so similar. The impact on oral health is also significant. The mouth is designed to be a moist environment, and saliva is our natural defense against tooth decay. It neutralizes acids, washes away food particles, and fights harmful bacteria. When a child breathes through their mouth, especially at night, their saliva dries up. This dry environment creates a perfect breeding ground for cavity-causing bacteria. As a result, children who are mouth breathers often have a much higher risk of developing dental caries, gingivitis, and halitosis, even if they have good brushing habits. Finally, the body works as an interconnected system, and changing one part can affect others. To keep the airway open, a mouth-breathing child will often adopt a forward head posture, tilting their head back and jutting their chin forward. This unnatural position strains the muscles in the neck and back, leading to poor posture that can cause chronic pain and spinal alignment issues down the road. It's clear that mouth breathing is not a minor habit. It is a red flag for underlying problems that can affect a child's development from head to toe, making it essential for parents and healthcare providers to address it comprehensively. For many years, the primary medical response to airway obstruction caused by enlarged adenoids and tonsils has been surgery. An adenotonsillectomy, which is the surgical removal of these tissues, is a common and often necessary procedure for children. Its main goal is to clear the physical blockage in the airway, and in this respect, it can truly be life-changing. When the procedure is successful, it immediately opens up the nasal passages, allowing the child to breathe freely through their nose for the first time in months or even years. This can lead to dramatic improvements in sleep, a reduction in snoring, and better overall health. The benefits of clearing the airway are, really well documented. Research, including a 2024 meta-analysis, shows that after surgery, many children experience what's called catch-up growth, gaining height and weight more rapidly. Their behavior and school performance can improve significantly as they start getting the restorative sleep they were missing. From a facial growth perspective, removing the obstruction can allow the jaws to begin growing in a more favorable, horizontal direction. By removing the mechanical barrier, surgery effectively reopens the main highway for air, setting the stage for a return to normal function and development. However, surgery is not a complete solution on its own. While it removes the physical obstruction, it does not automatically erase the of-mouth breathing that has become deeply ingrained. A child who has spent years breathing through their mouth has developed a specific muscle memory. Their tongue has learned to sit low, their lips have learned to stay apart, and their brain has learned that the mouth is the primary route for air. For many children, this dysfunctional habit persists, even after the airway is surgically cleared. They have a clear road, but they continue to take the old, inefficient detour out of habit. This is the critical limitation of a surgery-only approach. It addresses the anatomical problem, but fails to correct the functional one. The muscles of the face and the mouth need to be retrained to perform their proper roles. Without this crucial step of re-education, the benefits of the surgery may not be fully realized. The child might continue to hold their mouth open, the tongue might remain in its low position, and the abnormal facial growth patterns can continue, albeit perhaps at a slower rate. This is where a more comprehensive approach becomes necessary, one that not only clears the airway, but also actively retrains the muscles to use it correctly. Recognizing the limitations of traditional approaches, a field known as myofunctional orthodontics has gained prominence. This preventative approach operates on a simple but powerful principle. Instead of just straightening crooked teeth, let's address the root causes of the problem. It focuses on correcting the poor oral habits, the myofunctional habits like mouth breathing, incorrect swallowing, and improper tongue posture that lead to poor jaw development and crowded teeth in the first place. This is a shift from reactive treatment to proactive growth guidance, aiming to create a healthy, functional foundation for a child's smile. At the forefront of this approach is the Myobrace system. Myobrace is not a traditional set of braces that forcefully move teeth. Instead, it is a series of removable oral appliances, typically worn for 1 to 2 hours each day and overnight while sleeping. These appliances are designed to act as a personal trainer for the mouth and facial muscles. They work by actively retraining the tongue to rest in the correct position against the roof of the mouth, encouraging the lips to stay closed, and promoting the natural habit of breathing through the nose. It's about teaching the body to function as it was designed to. The Myobrace system is designed for children, typically between the ages of 3 and 15, during their most active periods of growth. The appliances are made from a soft, flexible material that is comfortable to wear. They do more than just correct habits. The unique design also helps to gently guide the growth of the jaws, encouraging the arches to develop to their full natural width. This process helps to create the necessary space for the permanent teeth to erupt straight, often reducing or even eliminating the need for traditional braces later on. It's a gentle, biologically friendly way to work with the body's natural growth processes. The philosophy behind Myobrace is that if you correct the underlying dysfunction, the structure will follow. By establishing proper nasal breathing and correct tongue posture, you restore the balanced functional matrix that guides healthy facial growth. This helps to prevent the development of the long, narrow adenoid face and promotes a well-proportioned facial profile. Myofunctional orthodontics with Myobrace offers a holistic solution that looks beyond the teeth to the overall health and well-being of the child, providing a pathway to a stable, healthy smile that lasts a lifetime. The Myobrace treatment journey is a structured, multi-stage process designed to systematically correct poor habits and guide healthy development. The entire program is a partnership between the clinician, the child, and the parents, with success relying on consistent daily wear and active participation. The process is typically broken down into 4 distinct stages, each with a specific goal. The first and most crucial stage is habit correction. This initial phase focuses entirely on retraining the fundamental functions of the mouth and airway. The appliance worn at this stage is very soft and flexible, designed to make the child aware of their tongue position and encourage them to breathe through their nose and keep their lips together. Once the foundational habits are improving, the child moves to the second stage. Arch development. The appliance used in this phase is slightly firmer and is designed to apply gentle pressure to the upper jaw, encouraging it to widen naturally. This is not a forceful expansion, but a guidance that works in harmony with the child's own growth potential. By creating more space in the dental arch, this stage addresses the core issue of crowding. It ensures there will be enough room for the tongue to rest properly in the palate and for the permanent teeth to have space to emerge without becoming crooked or impacted. This is a critical step in preventing future orthodontic problems. The third stage is dental alignment. As the permanent teeth begin to erupt, the Myobrace appliance for this phase has individual tooth slots that apply very light forces to guide them into their ideal natural position. This is fundamentally different from traditional braces, which often wait until all permanent teeth are in before moving them. Myobrace works with the eruptive process, gently steering the teeth into place as they emerge. This can significantly reduce the complexity of any future orthodontic work, and in many cases, may be all the alignment that is needed for a straight, functional smile. The final stage of the Myobrace journey is retention. Once the teeth are aligned and the jaws are well developed, the goal is to ensure the results are stable for life. The key to long-term stability is making sure the corrected oral habits, nasal breathing, correct tongue posture, and a proper lip seal are permanent. The retention phase uses a final appliance, often worn only at night, to reinforce these good habits and hold the teeth in their corrected positions until the child's growth is complete. This focus on retaining the function, not just the position of the teeth, is what sets myofunctional orthodontics apart and helps prevent orthodontic relapse. The recommendation for early intervention is not just a theoretical idea. It is backed by a growing body of clinical evidence and a deep understanding of childhood development. Experts agree that the earlier we address myofunctional issues, the better the outcome. The American Association of Orthodontists recommends a child's first orthodontic evaluation by age 7. This is because by this age, a child's first permanent molars and incisors have usually come in, and a trained clinician can spot the subtle signs of developing bite problems, crowding, and jaw discrepancies. This is a critical window of opportunity to intervene while the face and jaws are still growing. Research consistently shows that programs like Myobrace, when combined with myofunctional therapy exercises, are effective. Studies have demonstrated significant improvements in patients' overjet, incisor alignment, and overall facial profile. More importantly, these therapies are shown to successfully establish nasal breathing and correct tongue posture. By addressing the root cause, the results are more stable. One study found that adding myofunctional therapy to orthodontic treatment led to a 25% greater improvement in stability and significantly higher patient satisfaction compared to orthodontics alone. This proves that correcting the function is key to lasting structural change. The timing of this intervention is crucial because facial growth happens surprisingly early. By the age of 6, about 60% of a child's facial development is already complete. The midface, including the upper jaw, undergoes rapid growth between the ages of 4 and 7. Intervening during this period allows clinicians to guide that growth in a positive direction, using gentle appliances to widen the palate and create space. Waiting until the teenage years after growth is largely finished often means the problems have become skeletal. At that point, treatment is more complex, more invasive, and may require tooth extractions or even jaw surgery to correct issues that could have been prevented. Ultimately, the evidence points to a clear conclusion: early, interceptive treatment works. An expert consensus published in 2024 confirmed that early orthodontic intervention is effective for managing developing malocclusions, with a reported overall success rate of 75.5%. By catching problems like mouth breathing and poor tongue posture early, parents can help their children avoid more complicated treatments later on. This proactive approach not only guides the development of a healthy smile and a balanced face, but also supports better breathing, better sleep, and better overall health, setting a child up for a lifetime of well-being. Securing the best outcome for a child with airway and myofunctional issues requires a true team effort. It is not a problem that a single specialist can solve alone. The most effective approach is a multidisciplinary one, where different healthcare professionals collaborate to provide comprehensive care. This team often includes your pediatrician, who monitors overall health and growth, an ear, nose, and throat specialist, who diagnoses and treats physical airway obstructions, and a myofunctional orthodontist, who guides jaw growth and corrects oral habits with systems like Myobrace. In some cases, a speech or myofunctional therapist may also be involved to provide targeted exercises. As a parent, you're the most important member of this team. Your role begins with observation. Pay close attention to your child's daily habits. Do they consistently breathe through their mouth during the day, while watching TV or while sleeping? Do you hear them snoring or making gasping sounds at night? Look for the physical signs: an open mouth posture, dark circles under the eyes, a long and narrow face, or crowded teeth. These are not things your child will grow out of. They are clues that warrant a conversation with your doctor or dentist. Trust your instincts. If something seems off, it is always worth getting it checked out. The next practical step is to seek the right professional advice. Start by discussing your concerns with your pediatrician or family dentist at your child's next checkup. They can perform an initial screening and refer you to the appropriate specialists. Ask for a referral to an orthodontist who is experienced in myofunctional therapy and early interceptive treatment. You should also request an evaluation from an ENT specialist to rule out or confirm any physical blockages like enlarged adenoids or tonsils. A thorough diagnosis from all angles is essential to creating an effective treatment plan that addresses the root cause of the problem. Finally, remember that early action can make all the difference. The sooner you intervene, the more you can leverage your child's natural growth to guide them toward a healthier future. Correcting a breathing habit and guiding jaw development in a 7-year-old is far simpler and less invasive than trying to fix complex skeletal and dental problems in a teenager. By being proactive, you are not just investing in a straighter smile. You are investing in your child's ability to breathe, sleep, grow, and thrive. Your vigilance and commitment today can unlock a lifetime of better health and confidence for your child.